former commissioner of the New York City Health Department. Dr. Frieden is currently president and CEO of Resolve to Save Lives, his organization's name. Dr. Frieden began his public health career in New York City, confronting the largest outbreak of multi-drug resistant tuberculosis to occur in the United States. He was then assigned to India on loan from the CDC, where he helped scale up the program of effective tuberculosis diagnosis, treatment, and monitoring. And then he was asked to return to New York City to become the mayor, Mike Bloomberg's health commissioner. He directed efforts to reduce smoking and other leading causes of death that increased life expectancy by 3 years. As director of the US CDC, Dr. Frieden oversaw the work that helped end the 2014 West Africa Ebola epidemic. He now leads Resolve to Save Lives that works with countries to prevent 100 million deaths and to make the world safer from epidemics during the COVID pandemic. Dr. Frieden has overseen an expansion of Resolve to Save Lives activities, including policy and program innovatives in the United States, counsel to multilateral institutions, and support for rapid response, healthcare worker safety, and data-driven decision-making in more than 20 countries. So welcome you all to this special session. Please give a big hand for this gift from Dr. Tom Frieden.
Hello. I'm so glad to be speaking with you today, and sorry that I can't do this in real time. Thailand has been a leader for many years in public health and is still a leader in public health. I'd like to explore in the course of this talk how it might advance that leadership even more. I'll be talking about 717, an approach that can accelerate progress toward a safer and healthier world. Thailand's COVID response has been strong. You see the deserved praise from the World Health Organization for a response that is an all-of-society response that builds on the trust that the health system has earned from society to invest that trust in measures that further protect society and further strengthen that trust. Looking at the graph on the right side, you can see that Thailand is among the most effective countries in the world in keeping deaths from COVID low. Thailand also has other successes and progress to celebrate, including 40 years of the Field Epidemiology Training Program, the FETP. Thailand's FETP is one of the most mature and effective in the world, and it has given Thai leaders a strong basis in solid epidemiologic analysis that can help to find, stop, and prevent health threats. Thailand also has a remarkable history and present of collaborating with village health volunteers to support the healthcare system. It's truly a remarkable investment and a remarkable return on that investment, not in terms of money, but in terms of the health benefit to society. And it's a model for the world. The Thai Health Promotion Foundation is a global model for health improvement. And the Thai health model, this three-part triangle, this pyramid, is crucially important. It includes policy and system change, because policy change is the royal road to progress. Mike Bloomberg, former mayor of New York City, former and current director of Bloomberg LP, and the driving force behind Bloomberg Philanthropies, has said that when it comes to public health, education and other programmatic things are impressive, but it's really law and regulation that does the work. And he quotes the American writer Mark Twain, who wrote, "Thunder is loud, thunder is impressive, but it's lightning that does the work in the case of a storm. In the case of public policy, education may be loud and impressive, but it's policy and legal change that does the work. But that's only possible when there's also social mobilization to increase public awareness and change the context within which policy change becomes possible. And that in turn is only possible when there's knowledge, when there's research and evidence, so that we continuously improve the effectiveness and the knowledge base of our programs. We shouldn't think of research and program as unrelated. Everyone doing research should be thinking about the program implications of their research, and everyone doing program should be continuously evaluating and doing implementation science to improve the efficacy of that work. And the Thai Health Promotion Foundation is a great example and global model of using health taxes on tobacco, on alcohol, on unhealthy food to improve health. Thailand, though, does have the potential to make even more progress improving health and protecting health. Heart attack and stroke are the leading causes of death in the country. Tobacco use continues to harm far too many people, and although Thailand has made progress reducing tobacco use, there are other countries that have reduced tobacco use much faster, but more importantly, there are still far too many people in Thailand who are harmed by tobacco. Sodium consumption remains high, but there is consideration of taxation of sodium and other unhealthy foods, and that's very encouraging and could make Thailand a true world leader in this area. And despite an excellent and model primary healthcare system, 3 out of 4 people in Thailand who have high blood pressure do not have it under control. The COVID-19 pandemic shows that globally we need 3 things: a renaissance in public health to stop health threats quickly, robust primary health care to detect, respond, and preserve both health and productivity, and resilient individuals and communities to better withstand health threats. A renaissance in public health means that public health would be closely aligned across local, city, state, national, and global levels, aligned with political leaders so that we can prioritize evidence-based action and enable an all-of-society multi-sectoral approach that addresses the economic, educational, and social needs and potentials for effective public health action. Public health needs to, in some countries, regain, and in other countries, further strengthen trust, because trust is essential for disease detection and response. Public health needs to be equipped with real-time data to enable the best possible decisions, and public health entities need to be staffed by experienced, practical experts so that we can ensure that as more resources become available, they are turned into effective programs. 717 is a suggested target for the early detection and effective response to health threats. The idea is that every suspected outbreak would be reported within 7 days, that public health authorities would be notified and start to investigate and respond within 1 day, and that an effective response would be in place within 7 days. For this to occur, we know there is a need for more resources, for technical expertise, and for stronger organizations with improved managerial capacity around the world. The 717 target means moving from measuring capacity, theoretical capacity, to measuring what actually happens in real life when there's an epidemic, when there's an outbreak. The time to detect is the time from the date of public health threat emergence to the detection of that threat. The date of notification is straightforward when public health authorities are alerted, and the time to effective response is the time from that notification. At Resolve to Save Lives, we've worked with more than a half a dozen countries to evaluate close to 50 outbreaks to see if they met the 717 target. And what we found has been very interesting. These pilots demonstrate that 717 is feasible for most suspected public health threats, that it's a useful performance improvement framework to identify bottlenecks and enablers to improve the detection, notification, and response continuum, and that it identifies bottlenecks and enablers that are missed by other components of the international health regulation monitoring and effectiveness framework. It's part of the approach that WHO and others have advocated for years, looking at timeliness and after-action reports. It's a more systematic, focused, and objective way of doing that in a standardized way. It also identifies many bottlenecks that are low or no cost to improve in real time. This retrospective review of 41 events from 5 different countries identified that although the median time to detect was only 6 days, notify within a day, and respond within 7 days, the proportion meeting each of those targets was only 54, 71, and 49%, and more concerning, actually only about 1 out of 4 events met all 3 of those targets. That shows both that success is possible and also that there's a lot of room for improvement. 717 provides clear metrics for and a means of learning from every single outbreak. The idea is you input the date of emergence, detection, notification, early response, and completion of early response, and in very simple ways, calculate the intervals and determine yes or no. Was the target met? If no, at most 3 bottlenecks and at most 3 enablers. The early response is not just one indicator. It is a series of 7 different responses, some or all of which may be required for all outbreaks. An investigation and response team deployed, an initial epidemiologic characterization of the situation, laboratory confirmation of the outbreak etiology, case management, including, very importantly, infection prevention and control, initiation of medical countermeasures or of public health and social measures. Very importantly, for any significant outbreak, initiation of risk communication and or community engagement. And for a larger response, establishment of a focused, structured coordination mechanism. These are not controversial areas, but they're very important, and they need to be in place depending on the size and scope of the outbreak. Bottlenecks should be remedied through immediate improvement plans as well as longer-term systems improvements, and this has to be integrated into planning and budget cycles. Accountability for action is crucial. The idea is that entities would go from a watch mode, monitoring for potential outbreaks, to an alert mode when there is a suspected outbreak, to a response mode when a suspected outbreak needs to be investigated or responded to an improvement mode, identifying ways to make the next response better. This is a way of breaking another cycle. We've all heard about the cycle of panic and neglect. And unfortunately, we're heading very quickly into the neglect phase of that cycle when it comes to COVID-19. But there's another cycle that's very problematic, a cycle of planning leading to insufficient action. Rather than a long plan that may take a year or 2 to develop and then maybe not yet implemented, 717 allows every single outbreak to be used as a performance improvement exercise. And that will lead to immediate remedial actions for immediate implementation where resources are available or anticipated to be available. What's the action? Who is responsible? When is it expected? And what's the status? It also identifies longer-term planning and strategy needs. They may require more resources. They may require a multi-year response. It may be a matter of looking at the National Action Plan for Health Security and prioritizing things because you realize, oh, this is really important based on the performance in this last outbreak response. Public health needs to be agile and to engage communities. Situations can change rapidly, especially in emergencies. Agility and adaptability are essential. The COVID virus is adapting to humanity. If we're going to confront it effectively, we also have to adapt to the virus. That includes active outreach to marginalized communities, including those that may be alienated from healthcare and government services. We need to meet people where they are, physically and in terms of messaging and values communication. Trusted voices are particularly important and may be different for different communities and at different times. Moving on to the second key area, primary healthcare. Thailand is already a real leader in primary healthcare. It's a model. When I travel around the world, I say really only a small number of countries in the middle income range have excellent primary healthcare systems. Thailand is one of the very few that meets that category. In Thailand, you see healthcare, primary healthcare that is central to the healthcare system. That's accountable, high quality, staffed by multidisciplinary teams, which enable doctors to manage larger patient panels. That's patient-centered and offers convenient, affordable, and culturally competent care, and that is equipped to manage and prevent infectious diseases, diagnosis, treatment, vaccination, and strengthening individual, family, and community resilience against health threats. One area to explore further is the concept of capitation plus plus. Capitation is a set payment to providers per month or per year. It should be the basis of primary healthcare financing in the view of many. It does require empanelment, registration, gatekeeping, defining a bundle of services, and ideally risk adjustment for older or higher risk population. The goal is that long-term savings would be reinvested from tertiary care to primary care to improved health. That there would be team-based care, but this method of financing is quite rare in low and middle income countries. The first plus in the capitation plus plus model is fixed funding for infrastructure costs, larger in rural and slum areas. In Thailand, the health ministry has stipends to, I'm told, 1 million village health volunteers, and they provide essential health services during, before, and after COVID. They're also very important in the treatment of many diseases, but it's not just about volunteers, it's about the whole system, a primary healthcare system. The second plus could be carefully designed incentives, financial and non-financial, that improve the quality and the impact of healthcare. Healthcare shouldn't be merely about addressing patient requests, although that's very important. Healthcare should be about achieving the maximum health delta, the maximum health benefit for the investment that we're providing. Now, we know globally that adequate funding is necessary but not sufficient. And here, the United States is unfortunately a negative outlier. The US pays much more for healthcare and gets much less health. But even if you look within the rest of the OECD, you see that at a similar level of spending, there's an enormous variability in the healthcare system performance. So it's possible to spend better and it's possible to spend more. Most governments need to spend both more and better. On average, more investment in primary healthcare leads to better access and better outcomes. But even with similar levels of investment, it's possible to increase the health benefit for the health dollar. One of the areas that's been badly neglected is heart disease. Cardiovascular disease receives about 20 times fewer dollars per death than HIV. And if you look at this graph, in green is the global spend on the condition, in red the number of deaths. And what you see is that we have an appropriate level of spending for HIV, but a drastically inappropriately low level of spending for cardiovascular disease. And it shows cardiovascular disease remains our #1 cause of death, in significant part as a result of this long-term underfunding. In order to get more value for our healthcare system, one thing we can do is have countries select what's appropriate for them in a small number of indicators that can be accurately measurable. Simple, easy to measure, meaningful. If you get progress on this indicator, you're going to save lives. Minimal, the fewer indicators, the better. Maybe only 1 or 2 or 3 per year. And maximal, the greatest impact on morbidity and mortality. A lawyer, a public health lawyer I know used to say he believes in the 3M theory of public health, mitigating morbidity and mortality. Well, how can we mitigate morbidity and mortality? This is one example. You could focus on measles-containing vaccine 2-dose coverage, where relevant on malaria treatment, on protection against human papillomavirus, now a potential way to eliminate cervical cancer in the future. That's for children and adolescents. For adults, including women of reproductive age, you could include the met need for family planning with modern contraceptive methods, the use of nicotine replacement therapy for tobacco users. NRT, or nicotine replacement therapy, can double the likelihood that patients will quit smoking, and yet it's vastly underutilized. NRT isn't a way of rapidly decreasing the prevalence of tobacco use, but if you keep at it year after year, you can make a huge difference. This is something that is not widely understood. It's important to think of NRT and increasing quits in a time series approach. Let's suppose that you doubled the rate of quit of the 10% of people, 10% of smokers who try to quit. You've got roughly 10 million tobacco users in Thailand. It may be that 1 million of them try to quit each year. If you could give NRT to all of those people, you would increase quite substantially by hundreds of thousands of people over the years the number of people who quit successfully. And that would be prevented cancers, heart attacks, and human suffering. The portion of the population with hypertension effectively treated, and I'll speak more about that in a moment, diabetes care, community viral load suppression, and tuberculosis case detection and treatment success. One area, one country, one province, one health facility might just select one of these indicators or 2 of these indicators to focus on in a year and really think of changing not just their performance, but the structure of their healthcare delivery to achieve substantial progress. I would say begin with hypertension. High blood pressure kills more people than any other condition, and more than all of the common annual infectious diseases combined, more than COVID at its most deadly. And we know from elegant studies that starting with a systolic blood pressure of 115, every 20 millimeter increase in systolic blood pressure doubles vascular mortality at ages 35 to 69. Hypertension is the world's leading risk factor for preventable deaths, more than 10 million deaths a year. Of all adult primary care interventions, improvement in hypertension control can save the most lives. This is an analysis we did about a decade ago in the United States that showed that improving blood pressure control from the 40% range it's in now to a 70-80% range would prevent tens of thousands of deaths per year. However, most people with hypertension control globally don't have it under control, fewer than 1 in 7 globally. Reaching 50% global control would prevent 1.7 million deaths per year. And so a group has suggested 80-80-80, the goal that 80% of people would be aware of it and diagnosed, 80% treated, and 80% controlled, leading to about a 50% overall level of control. Globally, we're only at 14%. And although Thailand does better than that, at 23%, it's far from a leader here. Canada has that distinction, having reached about 68% control. Some of the Scandinavian countries and Korea, and Japan may have control levels above 60%. Effective control in Thailand could prevent tens of thousands of strokes, heart attacks, and deaths over the years. What you can see is that of the estimated 15 million people with hypertension in Thailand, only about 3.4 million are estimated to have it under control. That means more than 11 million people in Thailand are walking around, going to work, caring for their kids with uncontrolled high blood pressure. And with every heartbeat, they're at risk of a stroke, a heart attack, kidney failure. These are tragedies waiting to happen, and yet tragedies that could be prevented by deploying the superb primary healthcare system that Thailand has in the service of better control of high blood pressure. Controlling hypertension can be a pathfinder for improved and universal health coverage. Some of the key components of the heart strategy are examples of how to improve care and get more value from our healthcare system. First, a drug and dose-specific protocol. Agreeing on a protocol, disseminating, training, supervising, analyzing, optimizing, avoiding therapeutic inertia, which is all too common in many, many countries. This is evidence-based, cost-effective care. Second, quality-assured drugs and equipment, ensuring uninterrupted supply of drugs and validated blood pressure monitors. That means improving procurement, forecasting, and supply chain management. Thailand does well in this area. Team-based care, enabling nurses and others to at least refill and ideally titrate and follow a protocol established by doctors. This can be a model of team-based care. Patient-centered services, reducing the barriers of cost, travel, waiting times, attitudes, and knowledge, eliminating co-payments, providing 90 or 180-day refills for stable patients, addressing adherence, increasing patient confidence in the system, and systematic monitoring for continuous program improvement, tracking performance, identifying and solving problems, sharing positive lessons, encouraging healthy competition among facilities and areas, ensuring the accuracy of data, and a culture of continuous data-driven, patient-centered improvement based on data feedback loops. There are new WHO hypertension guidelines. Resolve to Save Lives was honored to be part of the technical group contributing to these, and there are key takeaways here, and some of them are quite relevant to what's happening in Thailand today. The first is to start hypertension treatment right away, as soon as hypertension is diagnosed. Risk assessment should not delay treatment. I understand that there's discussion making sure we're not over-treating hypertension. But the fact is, we are at great risk of under-treating hypertension, and that is a life-threatening decision. Often we put the burden on saying, should we start treatment? But remember, the decision not to start treatment is also a decision, and that decision might result in a preventable heart attack or stroke. Second, integrating team-based care into programs, and Thailand is a world leader at this. Third, increasing the length of prescriptions, as I mentioned earlier, to 3 or 6 month refills. Fourth, using a simple treatment protocol with preferred medications. And fifth, using single pill combinations, also known as FDCs or fixed dose combinations. This makes it much easier for the patient and the healthcare system. There's a very important trial called SPRINT, and it's worth going through for a moment. This looked at the comparison of treating to a target blood pressure of 120/80 compared with the usual target of 140/90. The death rate among people treated with the target of 120/80 was 27% lower. More intensive treatment is safe, although there is an increase in some adverse effects. More intensive treatment won't harm patients. In contrast, it might save their life. The biggest problem with care is under-treatment, not over-treatment, even if we decide to leave the goal at 140/90. We need to do a better job globally protecting our healthcare workers. In much of the world, there's a shortage of doctors, nurses, and other trained health professionals. We need to improve patient safety, including infection control, provide supportive supervision and ongoing training so people are learning throughout their career, ensuring that there's regular and competitive pay, providing socioeconomic and legal support, and providing an environment for monitoring, continuous improvement, and personal growth. Epidemic-ready primary health care would mean health care that can find, diagnose, treat, and prevent through vaccination and other measures health threats as they emerge. It will enable countries to meet the 717 targets for detection and response. It will also promote community resilience against COVID and future health threats. Primary care can monitor and improve the health of all, including through better blood pressure control and other preventive services. And primary care itself must also be sufficiently resilient to continue functioning, even with extreme weather events or other disruptions. It has to have specific infrastructure and procedures in place so it can continue core services during pandemics and other disruptions. Resilient individuals and communities mean communities that can be protected against health threats, protect productivity, and reduce healthcare costs. We can end the tobacco epidemic with comprehensive and well-enforced tobacco control measures. We can protect people from unhealthy food and promote wholesome, low-sodium, sustainable, farmer-supportive food production and distribution. We can promote healthy physical activity, including community redesign to promote walking and cycling. We can reduce air and water pollution. Water access and clean water will become increasingly urgent issues in the years ahead, and public health will need to go back to our water roots and promote safe and sufficient water for everyone in society. We can also reduce harmful alcohol use by following evidence-based policies, and we can protect children from addiction to tobacco, alcohol, drugs, as well as from predatory marketing by junk food companies. Resilient populations are healthier and they're better able to withstand health threats. COVID has been so deadly in part because so many people were vulnerable as a result of their poor health status and the lack of sufficient social safety net. Resilience is better when environments are structured to support health by making healthy behaviors the default choice. Environments structured to support health reduce avoidable illness, injury, disability, and death. They help reduce health disparities, and they can reduce risk and harm from future health emergencies. Community-wide interventions are very effective at improving health. These include high and increasing taxes on tobacco, alcohol, and unhealthy food, reduced contamination of air and water, policies that reduce disparities and inequalities, land use policies that promote physical activity and safe, active transportation, including bicycling and walking, and food policies that encourage healthier eating, including dietary sodium reduction, elimination of artificial trans fat, as Thailand has done, and measures to increase fruit and vegetable consumption. There's no reason we can't have delicious food that's not shortening our lives. Resilience also depends on trust in our public health and healthcare institutions. Public health and primary care systems need to work together to strengthen the trust and confidence of the population. Building and maintaining community trust can strengthen our ability to rapidly detect and effectively respond to disease outbreaks. Better communication and community engagement are critically important. The US CDC wrote the book on this. Be first, be right, be credible. Be empathetic and give people practical, proven things to do to protect themselves, their families, and their communities. Trust is one thing that cannot be surged during an emergency. Using metrics such as 717, stronger healthcare, and building resilient populations, we can keep the world much safer. Public health systems worldwide have suffered from years of underfunding. We need to strengthen and sustain core capacities to prevent outbreaks, whether natural, accidental, or incidental, or intentional, to detect threats early in order to slow or stop their spread, and to respond rapidly and effectively. We must break the cycle of panic and neglect and of planning and insufficient action. We cannot afford another multi-trillion-dollar pandemic, but we also can't afford not to collaborate and greatly reduce the risk of future pandemics. Thank you for what you do in Thailand to better promote health and protect health. We look forward to partnering with you, to continuing to learn from you, and to work together for a safer and healthier world. Thank you so much.
Thank you very much, Dr. Tom Frieden, for a very valuable speech. And he presented the 717 principles that is very crucial. And he also mentioned about the whole system to make primary healthcare work well together with how can we prepare for the next threat in the world. Okay. Now we are at the Q&A session. I proudly introduce our speaker to join in the Q&A session. Amanda Mcclellan. She is currently the Senior Vice President of Prevent Epidemics at the Resolve to Save Lives. She is joining us in the WebEx right now. Amanda leads a team working to accelerate progress to make the world safer from the next epidemic. She is a registered nurse and a notable expert in international public health management, epidemic response and preparedness, who brings more than 15 years of humanitarian and public health experience. Her achievements include coordinating frontline Ebola response during the 2014 Ebola epidemic, for which she received the 2015 Florence Nightingale Medal for Exceptional Courage, and publishing a landmark study on the impact of unsafe burial practices, which confirmed the life-saving benefits of comprehensive approach to Ebola prevention. She brings this expertise to the Prevent Epidemics Initiative, prioritizing and planning interventions and support in countries and regions at risk from future epidemics, and strengthening action packages in prevention, detection, and response to the epidemics. In addition to providing technical assistance directly or through partners, Amanda's team mobilized resources to support the preparedness and works to galvanize political will to address gaps in epidemic preparedness. Please welcome Amanda Mcclellan. Good evening, Amanda. Do you hear me well? Please unmute your mic. I can hear you. You already unmute. Okay, I can see that one. In the testing session, it worked well. ฝ่ายเทคนิคช่วยดูให้หน่อยนะครับ
Yeah, I can hear you.
Okay.
I haven't changed. Yes, you can hear me.
Good.
Okay.
I can hear you right now. Very good. So in case the audience and on site have a question, you can raise your hand and we will have the microphone. And also from the Facebook Live, in case you have the question in Thai or in English, our team will collect that to me. So before starting that, may I ask Amanda to have elaborate a bit about 717, because at that time the on-site audience cannot hear well in the clip. So what is 717?
Yeah, thank you so much for the opportunity to functionality of that system. We've been piloting in 7 or 8 countries now for the last 6 months, and we've really found it useful on a day-to-day basis inside the Emergency Operations Centre, a way to bring surveillance teams and response teams together, look at where we're achieving success and responding quickly, but also, most importantly, identifying where the system is weakest so that we can target systems improvements.
So it's not just only try to monitor how well we can meet that success about 7 days from the emergence of the public health event until notify and response initially within 1 day and 7 days with an effective measure. And in the video presentation is a link to a matrix or table. Try to find a strength, not more than 3, just only 3 strength or 3 weakness to improve. That is all right, and where that they implement this activity.
Yeah, so it depends on the outbreak, but we found to do better and more consistently. And so, you know, some outbreaks we can capture 5 or 6 bottlenecks, but it's really helping prioritize the ones that are most important or have caused the biggest delay, where we can really focus the energy to fix it. Dr. Frieden talks about find a problem, fix a problem. Bottleneck analysis really helps us identify where the system's not functioning together, and then really target that, fix it, and then move on, review it during the next outbreak and see how you've had an impact. And I think what we're finding is almost all the countries we've worked with are finding outbreaks in 7 days and responding within 7 days, about half the time, but no country's doing it consistently, and that's really where we think we can improve. Even countries that are doing very well aren't finding every outbreak quickly or aren't responding to every outbreak quickly. And so it's not just about improving the system for early detection, but our ability to do it consistently, not just in terms of time, but also parts of the country that might not necessarily have as much coverage or access to healthcare.
May I remind our audience again, in case you have a question, you can raise your hand and the microphone will go to you. This is a question from the Facebook Live. Very interesting. How can we improve the 717 target to generate value through public-private partnerships? And also another thing is, could you please indicate how to apply 717 target in monkeypox?
2 very good questions. So the private-public partnership, I think it's one of those issues that would really help us make the connection from detection in private system in particular. So comparing how long it takes you to detect and respond in an outbreak that's picked up through presentation in the public system, and then really looking at how you could include the surveillance system within the private sector as an example, making sure that you're using the private sector. In some countries where pharmacy, access to primary healthcare isn't always the first point of care, sometimes it's to the pharmacist. We've been starting to think through how could the pharmacist raise an alert or an event if they were seeing things that they were concerned about. So I think there's real opportunity to bring the private sector into 717 and help us understand where they can help us get quicker and more efficient across the system. In terms of monkeypox, it's a good question. Is it the first case? Is it the first case in the country, the first case in the district? We've been using monkeypox, for example, in the US. We've been measuring 717 from the first introduction into a new jurisdiction. So not just once into the US, but as it goes into each new health environment, health jurisdiction, how quickly that jurisdiction is finding that outbreak and being able to respond. But I think part of the message here is given monkeypox or an event like monkeypox, you don't have to wait for the first event to occur. You should be starting to prepare and get your surveillance system ready before the outbreak is introduced into your jurisdiction. So once it's been here in the US, we're actually pushing jurisdictions to say you shouldn't be waiting to find the first case. You know that you're going to get monkeypox sooner rather than later, and you should be preparing your systems, reaching out to your vulnerable communities, starting to think about vaccine early. So monkeypox, and we're trying it with a few other diseases like tuberculosis, which doesn't traditionally feel like a new event, but we have a group working on 717 for tuberculosis, thinking about finding that initial case and the 7 for response, really identifying the contacts, the household contacts for that tuberculosis case, making sure that they get on treatment. So we're trying it in a few different scenarios, including some endemic diseases.
Okay. When we identify the some event like in case monkeypox, so the way we find problem, fix a problem in case like I think some patient they may have some skin lesion for suppose 5 or 6 days or something, and then seek them for treatment. So it's just the last one day that we found patient and notify to meet 1 or 2 days, very quick. So the thing you've done in New Jersey is evaluation whether each event met the criteria, met the target of 717. Do they do it regularly every event?
It's true. So several jurisdictions didn't catch the first case or the second. They were getting third generation cases. But I think what it's shown us is if a patient is unwell with a rash, and it's difficult, right? Monkeypox, sometimes only 1 or 2 vesicles. But if patients are unwell and aren't accessing healthcare, that's helping us identify challenges with trust and access to care. So for Lassa fever, for example, in Liberia, we were getting very long delays in picking up the first cases. And when we looked at the bottleneck analysis, it was happening for 2 reasons. One, patients were coming late to the health facility, and so we were not picking up the outbreak early enough. But second, we didn't have clinical suspicion in our primary healthcare workers, and they were treating for malaria instead of thinking about other diseases. We're seeing something similar with monkeypox, and what it's helping us identify is really making sure we're communicating to physicians and primary healthcare nurses to make sure that their clinical suspicion is high for monkeypox. Anyone with a rash or potential at-risk profile is at least being assessed for monkeypox.
Okay, I'm looking for a question from the audience. Could you please provide the mic to Dr. Chulipon Jirapongsa?
Chulipon Jirapongsa from the Department of Disease Control. Actually, I can see that the 717 is a good indicator set for the notification of the first case. But how about the indicator for the monitoring of how good that we response, the quality of the response when the first case already been respond? Okay.
It's a very good question. So when we look at the first 7, obviously most responses go well much longer than 7 days. So why did we focus on 7? 7 days we think is enough time to start all the different components that you need for response. It gives you some time to start the logistics of getting vaccines ordered or starting your risk communications. But by no means do we mean that it helps you assess all of your response capacities. WHO has done a lot of work on building out the mechanisms for after-action reviews and inter-action reviews. So we think there's still a lot of value in assessing the completeness of your response using the normal methodology of AARs. But I think what we mean at the after-action reviews, but what we mean by 717 is really helping us focus in that subsystem, that important component where we need to react quickly, where timeliness really matters, and helps us improve the connection between the surveillance system and the response system. So 717 is a small piece of our monitoring and evaluation framework, the after action reviews is still a critical component in our ability to assess response more broadly and over a longer period of time.
Thank you. This issue is really interesting. There is another audience from the Facebook Live. I had a question, the same question, so I can skip that. Okay, right now, one more question from the audience on site. Please introduce yourself and ask question.
Thank you so much for your interesting presentation and very nice framework to providing us a very nice thing to battle with like the pandemic. So my name is Priya and I'm from the Office of Disease Prevention and Control Region 2. And I have a question about the resilient that you mentioned. So you mentioned about the resilient individuals and community that focus on like improving the health literacy. But I wonder about the resilient in terms of the public health that I think nowadays we mention a lot about this part and like the global health resilient as well, because I think coordinating between countries is really important in the pandemic. And I just wonder about your opinion about the resilience in terms of public health and global health. Thank you.
Thanks. Just to check, the sound wasn't great. The resilience of between public health. Yes. So, sorry.
Okay. Wait a bit. Okay.
Yeah. So I just wonder about so you mentioned about the layer of the individual resilience. So I just wonder about for the terms of like public health or the global health layers that we focused on improving our health system to be more resilient against the pandemic. So that's kind of, in my opinion, is very important, and we need a better coordination between countries to help prevent the future pandemic, or what we face now is monkeypox. So I just wonder about your opinion on that level.
Yeah, look, I would agree. I think the coordination, not just between countries, but between levels. So one of the things we've learned during 717 is that we focus a lot on the national level, strengthening the national level, especially in the bigger outbreaks. But actually that front line of primary healthcare is so critical to the resilience of communities and the overall health system. And so I think we've been focused very much on thinking about the different levels within the health system and then how that health system connects to the borders next to it and the region next to it. I do think we're going to see more regionalization. You know your countries best who are living next door to you. The threats, the culture, the interaction of diseases are going to be the most important in the surrounding area. So we have seen, you know, the new CDC or the new Public Health Institute coming up in the region will play a very important role. And I think Thailand has a very large role to play in terms of improving regional health security. And then I think globally, we have the new mechanisms with the IHR Review Board and the Pandemic Treaty. I hope that the pandemic helps us galvanize our approach to working better collaboratively as a public health team across many, many countries. But I do think it's going to take some time and commitment. But having common frameworks and common language and being able to meet together regularly, doing CIMEXs together, meeting at conferences regularly, I think are all important components of improving our response.
Thank you. I have one question from Facebook Live, and I would like to read it to let Amanda think back, because you had experience of Ebola response in 2014, right? If you get back to that day and try to implement the 717 there, this question is about, are there any obstacles during 717 implementation and how to solve it? And so the question, if you look back, in Africa, the resource is scarce. If they are going to implement, how should they start in their system?
Yeah, I mean, it's an interesting question. I think, the Ebola outbreak starting in a very remote place of Guinea, that first 7 turned into more like 70 or 80 days. And by the time we were able to detect, the outbreak had been going for several months. I think the last 2 big outbreaks, actually, we're about to publish case studies on Guinea and DRC Ebola outbreaks in the last 2 years. It still took them a month to find the first case. But once they found the first case and identified it, the response happened within 24 to 36 hours, including vaccination. So I do think 717 is very challenging in Ebola. It really needs alert clinicians picking up that first case. It's often the second case after we have a death. But I think the big takeaway and the lesson for me, I was in West Africa Ebola for more than 14 or 15 months. Was really the community engagement and trust and the power of misinformation and the need to engage with non-traditional public health actors. The critical piece that religion played at the beginning of Ebola has been spoken about a lot. It was a very big challenge to get the religious leaders to work with us on safe burials, to work with us in terms of helping spread messages. So I think the key there to some extent is really what we've talked about in primary healthcare. These areas didn't have access to healthcare even without Ebola, and it's about being there every day to treat the malaria cases and the diarrhea cases so that when we have to treat Ebola, the community know and trust the health system. We're able to communicate and collaborate with them. I think that was our biggest challenge in the first 12 months of Ebola was communication and collaboration with the communities to help them understand the disease, how it was spreading, and how they could work to stop it.
Thank you, Amanda. This session, the time is approaching to finish. I think for you may have some. I would like to ask you to say something about the NCD or other issue beyond the 717, and then this can be the last response, and we gonna conclude this session. Please, Amanda.
No, thank you. I think, Dr. Frieden gave a great overview, but I think people have always asked us why we work on preventing epidemics and hypertension. They seem very different diseases, very different approaches and programs. I think COVID has shown us how interconnected they are, that non-communicable diseases are a risk factor, not just for decreased morbidity and mortality in the population, but puts people more at risk for infectious diseases. And that fundamental layer of primary healthcare is so critical to both, to being able to get community access for early screening and diagnosis and treatment of hypertension, but also for early detection of outbreaks. And so that primary healthcare level remains extremely important for both teams within Resolve. And I look forward to learning from Thailand and other countries in terms of how we can replicate some of the achievements you've had in PHC and apply them in some of the countries where we work, especially in Africa.
Okay, thank you very much, Amanda. So the session is coming to the conclusion. Thank you. Hope we can meet later next opportunity. Okay, give big hand to Amanda.
Thank you so much.
Thank you. Bye bye. ครับผมก็ขอสรุปสั้นๆเป็นภาษาไทยนะครับก็717เนี่ยตัวเลข3ตัวนะครับก็คือถ้าเวลาเกิดเหตุไปจนถึงการที่ได้รับทราบระบบได้รับทราบเนี่ยควรจะภายใน7วันความท้าทายก็คือว่าถ้าสิ่งที่เกิดคือการเจ็บป่วยของเขาเนี่ยเข้าระบบช้าเนี่ยมันจะเสียเวลาตรงนี้ไปนานและบางทีการโผล่มามันอาจจะเป็นวันสุดท้ายของ7วันแรกนั้นมันก็จะดีเลย์แล้วเพราะว่าเขานับเมื่อเกิดเหตุก็คือเกิดการป่วยขึ้นมาใช่ไหมครับแล้วก็ภายใน1วันที่บอกว่าเลข1ตรงกลางเนี่ยนะครับคือการ response ออกไปสอบสวนแล้วก็มี initial response SRRT เรามีแต่ว่าถ้าสมมติว่าเราไปนึกถึงระดับอำเภอระดับจังหวัดแปลว่ามันต้องมีทีมที่พร้อมอยู่ไม่ว่าจะเป็นวันหยุดวันทำงานวันราชการมีเหตุขึ้นมามันจะต้องมีการ response ภายในวันเดียวนะครับแล้วก็ใน7วันถัดไปเลข7ตัวที่3ก็คือว่าเป็น7วันของมาตรการที่น่าจะดีกว่า initial response นะครับมีวิธีการมาตรฐานกับโรคนั้นที่ต้องทำยังไงจะไป trace คนยังไงจะไปสื่อสารกับคนที่เกี่ยวข้องยังไงนะครับอันนี้ก็จะเป็น717นะครับแล้วเขาบอกว่าในเรื่องของโควิดนี่เป็นการเชื่อมโยงนะครับให้เห็นมาสู่ระบบภาพใหญ่ซึ่งเขาก็เน้นดูที่ 3R นะครับ นะครับคำว่า 3R ของเขาเนี่ยอันแรกก็คือ robust ไม่ใช่ renaissance of the public health system การฟื้นคืนความเชื่อมั่นในระบบสาธารณสุขผมเข้าใจว่าในต่างประเทศเองจะมีปัญหาเรื่องคนต้านวัคซีนคนไม่เห็นด้วยกับระบบที่ Public Health จะไปแนะนำอะไรเนี่ยในช่วงหนึ่งก่อนโควิดนี่ก็คนไม่ยอมฉีดวัคซีนมีเซลจนเกิดการระบาดที่ยุโรปมีเจ็บป่วยมากกว่า 13,000 คนภายในประมาณปีครึ่งอะไรอย่างเงี้ยนะฮะเขาก็บอกว่าควรจะฟื้นฟูเป็นระยะฟื้นฟูเหมือนประวัติศาสตร์ของยุโรปมียุคเรเนซองส์มันมีคลาสสิกยุคมืดแล้วก็ฟื้นฟูวิทยาการนะครับและอันที่2คือ robust primary health care ซึ่งก็คือการจะเอามาเชื่อมโยงแล้วก็ให้มันเข้าถึงทุกที่ซึ่งเขาก็ชื่นชมประเทศไทยนะครับที่ทำได้ดีในเรื่องนี้แต่ก็ยังมีหลายอันที่เขายกตัวอย่างเรื่องของ Hypertension เนี่ยเราดีกว่าภาพรวมเฉลี่ยของโลกนะครับคนที่คอนโทรลได้ดีในเปอร์เซ็นต์ที่20 กว่าเปอร์เซ็นต์ในภาพรวมของโลก 14% จากที่ estimate ทั้งหมดที่มี Hypertension รู้ตัวเท่าไหร่คอนโทรลเท่าไหร่คอนโทรลได้ดีเท่าไหร่แล้วก็ target ของการที่จะคอนโทรลเนี่ยไม่ใช่แค่จะลงมาที่เกณฑ์วินิจฉัย Hypertension 140-90 ควรจะลงมาที่120-80ให้เป็นเป้าหมาย treatment เนี่ย over ไม่เป็นปัญหาแต่ under คือไม่ค่อยใส่ใจแล้วก็ให้นิดหน่อยแล้วก็หยุดแค่นั้นอันนี้เป็นปัญหาเขาบอกว่า systolic blood pressure 115เนี่ยทุก20มิลลิเมตรประหลอดที่เพิ่มขึ้นเนี่ยการเสียชีวิตจาก vascular cause เนี่ยเพิ่มขึ้น2เท่านะครับแล้วก็อันที่3นะครับก็จะเป็นเรื่องของ resilience นะครับความยืดหยุ่นของระบบการฟื้นตัวจากภาวะวิกฤตทั้งระดับ individual และก็ระดับ community นะครับซึ่งก็จะทำให้หลังจากโควิดเนี่ยเราก็จะกลับมาตั้งหลักได้เร็วขึ้นนะครับครับผมก็ต้องขอบคุณทางวิทยากรต่างชาตินะครับต้องขออภัยที่เซสชันนี้ก็อาจจะมีอะไรติดขัดอยู่บ้างแต่คิดว่าคงได้ประโยชน์แล้วก็ยินดีที่จะแชร์ในส่วนที่เป็นสไลด์แล้วก็ท่านอาจจะมาดูย้อนหลังนะครับใน Facebook ที่มันจะเรคคอร์ดอยู่แล้วดูได้เต็มๆครับก็ขอปิดเซสชันเพียงนี้ขอบพระคุณทุกท่านครับสวัสดีครับ
สุดท้ายนี้นะคะดิฉันขอบคุณท่านวิทยากรและผู้ดำเนินการอภิปรายที่ได้ให้เกียรติมาร่วมการอภิปรายในครั้งนี้ค่ะและขอบคุณทุกท่านนะคะที่ให้ความสนใจในการปาฐกถาพิเศษในหัวข้อ 717 กลยุทธ์การจัดการโรคติดต่อเพื่อโรคปลอดภัยจากการระบาดค่ะ
เห็นบางท่านแอบลุกในเซสชันต่อไปนะคะเป็นเซสชันของกองโรคประกอบอาชีพกองโรคจากการประกอบอาชีพและจากสิ่งแวดล้อมนะคะโดยในเซสชันนี้นะคะก็ได้ยินคร่าว